Welcome to The Coalition. This is a talk show dedicated to discussing health, wellness, and inspiration. I'm your host, Dr. Shani Belgrave. Hello, everyone. Thank you so much for joining The Coalition. I'm your host, Dr. Shani Belgrave. I am a bariatric and minimally invasive surgeon in Atlanta, Georgia. I'm also the founder of Onika Bariatrics and Wellness. You can learn more about me and get connected at www.drshanibelgrave.com. I am excited to welcome to the show today Dr. Erica Bove. Dr. Bove is a double board certified OBGYN and reproductive endocrinology and infertility specialist who joins the show to share her expertise. Dr. Erica Bove, thank you so much for joining the coalition.
Thank you, Dr. Shani. It's such an honor to be here.
I am grateful to have you joining us all the way from the University of Vermont. So you're located in Vermont. Please tell us a little bit about who you are and what you do.
Absolutely. So my passion is helping people build their families. And I am a reproductive endocrinologist, which means a lot of what I do is helping people get pregnant, stay pregnant, all those things. Also, we do a lot of like menopause, abnormal puberty, those kinds of issues as well. But my other hat is that I am the founder of Love and Science Fertility, which is a coaching practice where I help high achieving women to build their families, because we know that 1 in 6 couples has infertility, 1 in 4 female physicians has infertility, actually 1 in 3 surgeons, you're a surgeon, 1 in 3 surgeons has infertility. And, through a very scientific approach and also a very compassionate approach, I help people become parents, and it's so beautiful.
Yes, that's amazing to be part of such an important journey. So what are some of the most common fertility challenges that people face, and how do they know that it's time to see an expert?
Absolutely. So one of the most common challenges we see is what's called diminished ovarian reserve. And that basically means that, we know that we're born with all the eggs we'll ever have, but we lose them slowly with time. And, when I see somebody in my practice who's maybe like 38, 40, 42, we know that at those ages, usually not just the egg number goes down, but the egg quality gets worse with time. And so trying to help people get to that good egg, right, and really help build their family, that can be a struggle sometimes. So that's one of the hardest problems we treat. A lot of people are, just simply not ovulating. And I always say, your clock is that you guys have been trying for 1.5 years. However, if you're never ovulating, then, there's never really been sperm and egg exposure. And so we help people with that too, help them ovulate. But I think one of the other things that people don't realize is that up to 50% of infertility is actually male factor. And so a lot of people poke and prod the female in a heterosexual relationship. But I think it really is important to look at the male side of things if, when appropriate, and on the sooner side, because there's a lot of things that we can find and treat, especially as it pertains to the couple as a whole. And so, to your point about when does it make sense to see a specialist, the recommendation is if you're under the age of 35 with regular sperm exposure, it makes sense to wait 1 year before seeing somebody like me. If you're 35 or older, because of that diminished ovarian reserve problem we talked about, if you've been trying for 6 months and things are not connecting, then, go, because sometimes waiting longer is not helpful, with some caveats, right? So if you're never having a period, if you're not ovulating, don't wait the full year, come see somebody sooner. Or if you have, risk factors for fallopian tube disease or anything else in your history where it's like, okay, well, maybe there's something deeper going on, then, go see a specialist to make sure that the tubes are open and we can check the various components.
Yeah. Fantastic. So what are some myths? Are there some myths that you have heard patients express and then come to find out that when you explain it, turns out they are in fact myths? Myths versus reality.
So many myths. I spend my day busting myths. I think, one of them, and people come with a lot of shame, actually. People say, like, are we doing it wrong? Am I, we have to put our feet up and we have to wait this amount of time, or, depending on your audience, like just a lot of physical concerns that things are not, going the way they're quote unquote supposed to. And, we all learn how not to get pregnant, right, in education, but nobody is like, okay, this is how you do try to get pregnant. It's just assumed it's going to happen. And so, I do a lot of myth busting. Usually it's not the mechanics that's the problem. I do a lot of normalizing about, the various aspects of sexual activity. So that's one myth, is that, it's the mechanics. I think another myth is that it's all on the woman. Like I just said, up to half of infertility is actually male factor. And up to 40% is male and female factors combined, because it's like nature's redundancy gets knocked down. And so, really making sure we're doing the male evaluation on the sooner side. And another myth I wanted to sort of bust is that working harder is better for the process. And what I mean by that is, who I see in my medical practice and my coaching practice is a lot of high achieving women, and we push and we push and we push. And sometimes that's not the right energy. Sometimes pulling back, looking at the big picture, we always think, IVF is the best, in vitro fertilization. Sometimes actually taking a step back and optimizing lifestyle, or maybe doing, sort of less involved therapy, is what actually gets people pregnant. So it is not a one size fits all approach. We need tailored care, and there's actually a lot that can be done. And most people who stick with this process are ultimately successful. Not everybody, but most people.
Well, that is good news. That was the perfect segue to my next question. When you talk about the tailored approach, what are some things that people can do as it relates to diet? Does diet play a role in improving fertility, and also stress?
Absolutely. Okay, so diet. I always tell my patients, and it's hard because there's not like a one size fits all diet, but there's certain principles that seem to, be true regardless of the population. So eating from the outside of the grocery store instead of the middle, because in the middle, that's where all the processed food is. On the outside of the grocery store, the perimeter, is where you have your whole foods, your fruits, your veggies, right? Some of the more whole grains. And so I know it's more expensive, and, it takes some intentionality, but those foods seem to be best for the microbiome. I know you've done an episode on the microbiome before, and the microbiome is this like fascinating machinery that affects our brain chemistry. It interacts with the microbiome in our gynecological tract. And so what we're finding is that when people have a diet rich in antioxidants, that tends to be more favorable for the process. And, directly the egg health as well. The uterine environment, absolutely, but the egg health too. And, I think in terms of like some people, not everybody, but some people are more prone to, pro-inflammatory foods. And so if we look at like this Western diet that many of us adhere to, it's not always the best for fertility. So I don't think people have to like super stress out and, drive themselves crazy. But I do think that if you are somebody who doesn't feel good after you have dairy, if you're somebody who doesn't feel well after you have gluten, pay attention to the body signals, because intuitive eating is where it's at here. Yes, high protein. Yes, lower the processed foods, all those things, but listen to your body and what feels good to you, because if you're bloating after meals and things like that, that's probably not going to be helpful for your fertility. Yeah. And stress. You asked about stress too, but I can talk more about diet.
Yeah. Part two of that question. I can never miss an opportunity to echo when someone says to cut back on processed foods, because in all the organ systems, it tends to wreak havoc. And so it's no surprise that fertility and the reproductive organs are susceptible to them as well. So go ahead. Yes. We're going to
I can talk about stress, but it's really interesting because, when we have these processed foods, our gut microbiome adapts, and then we crave more of the processed food. So people talk about this sugar addiction. It is real. But when we can break that addiction, when we can prefer the things that are good for us, it's not about willpower. I promise you, it's not about willpower. It's about starting to crave the things that are good for us and being like, oh, those almonds, those look really incredible. Or, oh, that, it's, chia seeds. Like, when we start to really crave those superfoods, that's when we start to see our bodies working better. And so we have to break the sugar addiction. We have to right our inflammation in our brain chemistry. Anyway, you asked about stress. So, stress, I think, is that variable that people do not pay attention to enough. And oftentimes it's truly the missing link between people having unsuccessful treatment and successful treatment. It's the whole reason I have a coaching practice. So, just to think about physiology, when we're stressed out, that activates our adrenal glands, right? And our adrenal glands pump out all these hormones that increase our blood pressure, increase our heart rate, put us in a state of threat, of danger, right? And that's adaptive. We need, if we're being chased by a bear, we need that response. But if the fertility journey can last not even weeks, not even months, but sometimes years, it is not good for us to be in that state. It increases inflammation. It worsens our sleep. It takes a toll on the reproductive system. And so, one thing I've learned to help people with is actionable strategies to reduce stress surrounding fertility treatments, surrounding work stress, surrounding relationship stress, all this fertility journey that affects our relationships, coming home to ourselves, having a mindfulness practice, whether it's journaling or meditation or going for a run, whatever it is, like we have to learn how to discharge stress, process our feelings, put the fertility journey in perspective, and also come together in community. I mean, isolation, there's a reason that when people are torturing people, right, they isolate them, right? Infertility is so stressful, it's so shameful, and we are also isolated when we're going through this. So when we can come together in a group setting, in a supportive, safe space, that will automatically lower the stress levels, and it's just amazing, and magic happens. I mean, it's just beautiful.
Stress management. So,
Yeah.
when you mentioned in vitro fertilization as a potential treatment for infertility, what else can you tell us about treatment of infertility?
Absolutely. So it all starts with what the diagnosis is, right? So there's different reasons that people might have infertility. Thinking very simplistically about eggs, sperm, tubes, and uterus, right? Of course, there's chronic disease and other things, but very simplistically, those are kind of the components. And so we can check the egg number. We can look at age. I mean, that is one of the things that is so hard about this, is that we are the age that we are, and that is the one like non-modifiable variable is our age. But we can work with that to make ourselves as healthy as possible, right? So there's eggs, we can check the sperm, we can check the fallopian tubes, and we can check the uterine cavity. And once we like kind of figure out what's going on, oh, maybe somebody's not ovulating, or oh, maybe the sperm are, there's some of them, but they're not the best quality. And so maybe we can look and see what we can do there. Or maybe somebody has endometriosis, which is when people have uterine lining tissue that's outside of the uterus, and that can create inflammation and scarring and fallopian tube, issues as well. And so really understanding that initial appointment is so important, taking a very careful history, understanding, how long has somebody, not just been trying, but not preventing, right? Because that sometimes, oh, I've been trying for a year, but I haven't used birth control in 10 years. That's really important to know. So once we know what the diagnosis is, whether it's an ovulation issue, a sperm issue, a combination of the two, significant fallopian tube issues, maybe it's a big fibroid that's, affecting the uterine cavity, and we can take that out and make things better. The treatment really starts with what is going on. If it's a structural problem, we try to fix the structural problem with surgery. If it's a hormonal problem, then we try to help somebody ovulate. I mean, that is the simplest thing we do, is we give somebody a pill called letrozole, and we can truly, if they're not ovulating or not ovulating well, we can give them an ovulatory cycle, which then gives them a chance at conceiving that month. And so that's one treatment, is ovulation induction. And another treatment is what we call controlled ovarian hyperstimulation, which is a lot of words, but basically means that we're intentionally helping somebody ovulate, say 2, 3, 4, 5 eggs. Obviously depends on the age to make sure it's safe to do that. But because we think that there's an egg quality issue, or maybe it's age, or maybe it's endometriosis, we can help people super ovulate, like ovulate a few eggs at a time, and then combine that with inseminations, where we put the sperm directly through the cervix into the uterus, which can optimize the chances of a good sperm meeting a good egg. So that's another line of what we do. Sometimes it's just male factor, and we can, if the sperm are not quite good enough for intercourse, but not so bad that we need IVF, we can actually just bypass the cervix, put the sperm right in the uterus, and many women will get pregnant with that alone. So it really depends on what people need, but there's certain situations where we need to go to in vitro fertilization from the very beginning. So if somebody has really, really severe male factor or very low sperm counts, or say somebody has no tubes or blocked tubes, those are situations where it's really not going to happen in a less involved, treatment approach. And so that's where we might go there directly. Or if somebody's done a number of these treatments and it hasn't worked, or if somebody's like 39 years old and they want 3 children, we don't want them trying at the age of 45. So, we might take a little bit more bold approach from the beginning. So for the listeners, what is in vitro fertilization? It's a 2-week process of stimulating the ovaries to produce as many eggs as is safe in that cycle. We actually go through a group of eggs every month, not just one egg at a time. That's how our bodies work. So instead of having one dominant follicle like we do when we typically ovulate, we actually bring up all the supporting eggs as co-dominant eggs or co-dominant follicles. And so through hormones, the same hormones that exist inside the body, and people come in like every other day for ultrasounds and blood work, we can then grow the cohort to a point where you have as many mature eggs as is safe for the person to have. So you can have, if somebody's max potential is 3, then we get 3. If somebody's max potential is 25 and it's safe to do so, then we get 25. So it's highly individual, but it's a 2-week process of stimulating the ovaries. It culminates in an egg retrieval where we put the woman under anesthesia. We do a transvaginal egg retrieval with a needle through the vaginal wall right into the ovaries. We look at the ultrasound screen. I'm going to do it tomorrow morning. And we take out the eggs, and then the lab then looks through that follicular fluid and, takes out the eggs. Later that day, those eggs are fertilized with sperm. And then we either do an embryo transfer in that same cycle, so bypassing the fallopian tubes, taking an embryo that's been created in the lab, putting it right back into the woman's body, or there are some situations in which we, create the embryos, but let the body calm down, let the woman have a period, and then come back in a different cycle and, thaw a frozen embryo and put that in. Success rates, even in my own career, have just dramatically increased. And it's, I really do feel like we help people with these miracles every single day.
Yeah. Wow. Well, thank you so much for breaking that down in such detail and also making it clear. So what would be your takeaway message? Like people who maybe haven't personally experienced infertility, but are curious, want to learn more about it. What would be the one thing you want them to take away from this episode?
Okay. So if you are even thinking about having a family, right? And, whatever age you are, just know that time is going to keep passing. And the more time that passes, the harder it's going to be. And so I see a lot of people who are like, medical students at the age of 28 and are like, I think I want to have a kid in 10 years. If family building is a priority for you, think about it on the early side. Freeze your eggs, right? Again, talk with your fertility doctor about this, but it's a really, really safe and effective thing to do. And, maybe somebody is partnered and they're just like, oh, I don't think it's a good time. You can freeze embryos. You can make a plan of when you want to start a family or when you want to start trying, because I see too many people who lose track of time. And we know 5, 10, 15 years, 20 years. I had a patient come and say, we just kind of forgot about it. And here we are and we're in our 40s. And, I see this all too often. And so if this is a priority for you, talk with a specialist, make a plan, whether it's fertility preservation or actively trying to get pregnant on the soonest timeline, get some body awareness, get some data, and start, building this into your life now, because there's so much regret. There's so much that I see. And that's the one thing is, if this is at all in the realm of what you're hoping for in your life to have a kid or more, go see a specialist and just make a thoughtful plan. Yeah.
Oh, that's excellent. An excellent takeaway. I had to smile when you said 20 years can fly by, because I'm like, what do you mean it's 2026? So yes, time definitely does fly. Well, thank you so much, Dr. Erica Bove. For people that have enjoyed this episode, what is the best way for people to connect with you?
Absolutely. So my website is the most comprehensive place. It's loveandsciencefertility.com because it takes both. I'm also on anywhere of the social media places. So on Instagram, Love and Science Fertility, Facebook, same name. I'm on LinkedIn. And then I also have a podcast called Love and Science Fertility. So check it out. I'm also at the University of Vermont if you're a patient in the, Vermont, New York, New Hampshire area, but my coaching practice is international. So if you're stressed out, if you're feeling disheartened by the process, treatments aren't working, those are the people I love to help in the coaching. Yeah.
Awesome. Well, thank you so much, Dr. Bove. I hope to see you back on the show another time.
I would love to do that. Thank you, Dr. Shani.
Thank you. Well, everybody, thank you so much for tuning in to another impactful episode of The Coalition. I'm your host, Dr. Shani Belgrave. I am a bariatric and minimally invasive surgeon in Atlanta, Georgia. I'm also the founder of Onika Bariatrics and Wellness. You can learn more about me and get connected at www.drshanibelgrave.com. Very special thank you to Dr. Erica Bove, an accomplished double board certified OBGYN and reproductive endocrinology infertility specialist in Vermont. She also has a international coaching practice. You can get connected with Dr. Bove through her website or on social media. Make sure you share this episode with friends and family to spread awareness about fertility. I'll see y'all next time.